was a 12-week study. We evaluated 3 doses of 74809 with a 2-fold increase across the dose range, across each of the dose levels. So we have 40, 80, and 160 milligrams given once daily. This was compared to placebo. We had about 22 to 23 patients for each of these groups. And we allowed approved therapies or standard of care therapies for the treatment of IPF, but we also stratified so it would be evenly distributed across the groups. And we had as a primary and secondary endpoint for the study, safety and tolerability was the primary, and then pharmacokinetics was the secondary. And the exploratory endpoints included evaluation of the endpoint that is registrational for approval of therapies. So that's forced vital capacity. We also included biomarker imaging that was based on HRCT or high resolution CT scans. And this is a technology that is able to measure the degree of change in terms of the scarring in the lung with computer algorithms. So it's a technology that's been around for quite a while and has been used both in the natural history setting, but also recently in interventional studies. So we were excited to include that because it's certainly something that, in terms of 74809's mechanism of action being an antifibrotic, we wanted to see whether we could see these changes in fibrosis would be manifested using imaging, because FVC as such is certainly also correlated with the progression of the disease, but it's not necessarily purely a mechanism, if you wish. Like having less fibrosis should lead to better FVC. However, there's a motivational aspect in doing this method, this measure for patients, and we know that there are certain limitations it's not necessarily always in line. You don't always need an antifibrotic mechanism to see a change in FVC because of these aspects, but we wanted to be very thorough in evaluation because we had done a lot of previous work, mechanistic work, to show that our drug is acting on its target, alpha V beta 6. This was in IPF patients, in the lungs of IPF patients, and we also had seen in healthy volunteers that it was able to reduce TGF-beta activation in the lung with short-term dosing. So for us, having a technology like QLF would give us a different read, but certainly support the mechanism of the compound. And so what we did is we treated these patients for 12 weeks. And just in terms of the summary of the results, we saw very favorable safety with no discontinuations due to adverse events. We had no drug-related serious adverse events. We had enrolled a patient population that approximately 80% of them were on standard of care regimens. So that's also very nice to see that in addition to existing therapies, our drug did not add to the toxicity liabilities for the existing agents because you had no discontinuations because of 2,2-AEs. But importantly, in terms of the exploratory efficacy markers, we saw dose-dependent improvements in forced vital capacity over 12 weeks. This was a really beautiful finding because we weren't sure if we would see these changes manifest as early as 12 weeks, but in our study, we've seen them, and the strong efficacy signal was present based on what we considered or what is considered the registrational endpoint. But we also saw the consistency in terms of the QLF score, which I talked about, the biomarker imaging, where we also saw these dose-dependent changes. And that really supports the mechanism of action of the drug. In addition to that, we also had serum biomarkers of fibrosis, and we saw dose-dependent changes in these biomarkers as well, further supporting the antifibrotic properties of our compound. So we're really, really excited that we could learn so much in what is a 90-patient study that has a 12-week duration. There was only one adverse event that occurred with an incidence of 10% or greater, and that was mild to moderate diarrhea, basically. And that was, we looked back at who experienced these diarrhea, and I think the incidence roughly 17 or 18% of diarrhea in the combined 74809 groups. When we looked at those cases of diarrhea that were drug-related, that went down to 12%. And then when we looked at who were these patients that had this mild to moderate diarrhea, these were patients taking, the 12 out of the 13 were taking nintedanib. So if you're familiar with nintedanib, that's really the key adverse drug reaction is diarrhea. In fact, in the registrational studies that are described in the LeFebvre label, you have 62% rate. So it's pretty high. And certainly the fact that we had 18% in terms of our compound, our data suggests that it's really well below what you typically expect to see with a standard of care agent. Importantly, no patients discontinued due to diarrhea, and also in our phase 1 evaluation, diarrhea was reported very infrequently in these studies. So we also saw that this diarrhea was only in the presence of standard of care, was not with 809 or 74809 alone. So it's, for us, it seems that this could certainly be associated with the background therapy that these patients were receiving. You know, we have everything we need from the data from this study to engage with the regulators in terms of getting a sense of whether they, getting some guidance or feedback on our proposed late-stage development approach. And we're planning to have a meeting with the FDA later this year and the EMA early the next, most likely. And what we'll be discussing is something that we're really that would really provide a program that would provide robust phase 2B evaluation, so we can really be confident in the dose we're selecting for phase 3, but also that allows for efficiencies, and an adaptive trial design is what we're looking at to do that, because it can really accelerate your time to NDA. However, these adaptive designs, even though the FDA has guidance on running adaptive designs, and they've done it also, the respiratory division has done it for drugs in asthma and COPD. They've never done it for IPF. So for us, we want to know what their appetite is for contemplating such a study design in IPF. And we'll be also including the data from this study as part of this, this interaction. We don't need the results for the 320 milligram cohort to have this interaction, because we already have a strong efficacy signal on top of the great safety we saw. But the 320 milligram cohort that's been fully enrolled at the end of June, the 12-week results from that cohort will read out in early 2023. So, by the time that we get the regulatory feedback, also we'll have the 12-week data for the 320 milligram dose. So we'll have a much more rich information to determine our next steps, and where, certainly as it relates to the dose selection, let's say the study design for late stage doesn't depend on the 320 milligram group, but the dose selection for late stage will certainly be informed by this group. So, in early 2023, as I mentioned, we'll just get a lot of information that is really going to help us decide what's going into phase 2B. Ideally, these are 2 doses, right, that we bring forward, and then we select a dose in phase 3. In terms of the progression of IPF, that's also something that is a little bit hard to predict. We know that, for example, if you think about liver disease, if you're pre-cirrhotic, you have a great chance of becoming cirrhotic. So, we expect that patients that are pre-cirrhotic, could become cirrhotic in the trial study. I mean, a trial in a study that evaluates treatment. But for IPF, past prediction doesn't predict future progression, or past progression doesn't predict future progression. So that's a little bit the challenge. But what's known is that if you look at categorical change in FVC of 10% or greater in percent predicted FVC, so that's also one of the data that we presented, where we saw the clear dose response was in that more stringent endpoint looking at FVC. This is giving you, for example, if you achieve a greater than 10% progression in 12 weeks, you have a twofold increase in mortality or disease progression in the next 2 years that follow. So this is really important data for us because we see that, you know, it is going in line with the dose response we saw for the biomarker imaging as well. So these two sets of data show a nice dose response, and the big difference between the 160 milligram group and the placebo group for that 10% increase are really quite striking. Just for the relevance of what, you know, I talked about the clinical relevance of that threshold of 10% relative change. It's also part of the regulatory, it's a regulatory meaningful endpoint because that degree of progression makes it into the clinical outcome measures that you evaluate in addition to death and respiratory related hospitalization. So usually for clinical outcomes, it's composite endpoints that include that threshold. And that is also reflected by, if you look at the Esbriet and the LeFebvre labels, they have a very clear description of the proportion of patients who meet that threshold in their studies. So it's something that if you go back to, you know, the LeFebvre or the Boehringer, the Esbriet websites, they use that as part of their promotional material. So when we're thinking about, you know, building really a competitive and differentiated compound for the treatment of IPF, we're really putting all our efforts to really make sure that we can, you know, at the time that 74809 would get approved, if everything goes to plan, we're going to maybe be in a more crowded market, but we want to also have a really clear definition of, you know, these progression that you can see, and also the effect that you can see with or without standard of care in phase 2B. And maybe that's a quick point to make, that we really want to increase our proportion of patients not on standard of care to about 30% in our late stage evaluation. So we have a really good, you know, good data there to support the label.